Welcome, everyone, and thank you for joining today's webinar. This is Bill Schmidt, President and CEO of the Pulmonary Fibrosis Foundation. I hope you are all doing well in these challenging times. We know this is a particularly scary time for people with pulmonary fibrosis, but know that we are here to help in any way that we can at the Foundation. The PFF is closely monitoring the COVID-19 outbreak, and we're continuing to focus on our work for the PF patient and caregiver community. Our staff team is working remotely, not surprisingly, but we are committed to working creatively to maintain all of our activities and to maintain the availability of our information and services for the community. We are also in ongoing contact with the PFF medical team, which, as you know, is world-class. We have a new COVID-19 landing page on the PFF website with resources for the community, including PFF guidance on COVID-19, patient frequently asked questions, links to the Centers for Disease Control and Prevention, Johns Hopkins University, the World Health Organization, and other important websites. Through our government relations program, we are also active in the public policy arena on issues that are affecting patients and caregivers. The PFF recently initiated a letter to the Centers for Medicare and Medicaid Services, the agency that oversees Medicare. The PFF asked specifically that during the current crisis, the agency waive the in-person testing requirement for patients who are receiving oxygen for the first time, as well as the in-person testing requirement for patients who need to be recertified for their existing oxygen prescription. The PFF also asked that the agency waive the signature requirement for delivery of supplemental oxygen. We were able to recruit 8 other national organizations to join this effort, including the American Thoracic Society, the American Lung Association, Pulmonary Hypertension Association, and others. And I'm really pleased to report that Monday evening, CMS issued guidance effectively waiving the in-person test requirement for oxygen, as well as the signature requirement for delivery of all durable medical equipment. So hopefully that will really make an improvement for people who are needing oxygen right now during this time. We are also doing all we can to proceed with important scheduled activities at the Foundation. So for example, our new PFF ambassador training is taking place virtually this week. Likewise, our PFF walk in New York City, which was scheduled for April 25th, will be a virtual event. I want to close my remarks with just a few reminders. Please stay in close touch with reliable sources of information, such as your state government and the federal government and the CDC. Follow their guidance as well as the guidance of your physician. Communities are continuing to add resources for support of those sheltering in place. If you need help, contact your mayor's office or your local area agency on aging. Those exist in many localities. And of course, for support from the PFF, please call the Patient Communications Center at 844-825-5733. Again, that number is 844-825-5733. We are here to help. It's now my pleasure to introduce our featured speakers today. Dr. Amy Hajari Case of Piedmont Healthcare in Atlanta, Dr. Sonye Danoff of the Johns Hopkins University School of Medicine in Baltimore, and Dr. Rob Hallowell of Beth Israel Deaconess Hospital in Boston. I really want to thank them for being available for this webinar today. As you all know, healthcare professionals are being pulled in multiple directions right now due to this crisis. In addition to their important work for the PF community, I also want to thank them and all their fellow healthcare provider colleagues for their commitment and incredible courage in being on the front lines of this pandemic. So I'm going to stop there and turn it over to Dr. Case.
Thank you, Bill. I am very happy to be here and just thrilled to be joined by Dr. Danoff and Dr. Hallowell and have this opportunity to speak to our community, understanding that there is a lot of anxiety about what's going on in the world right now with COVID-19. And among everybody, I think that's dealing with this. And just we hope in this brief time that we have with you to be able to give some factual information, talk a little bit about what we know and what we don't know, and answer some of your questions, maybe reduce some anxiety, but bring some facts to the conversation here too. As we always do, we address disclosures. None of us have any disclosures that are relevant to the topic at hand. And what I thought I would do is kick it off with just a little bit of information about what is COVID-19 and what is the coronavirus. If you have gotten into any of the news, you realize that this is something that's in the current event sphere right now. But if you skipped to just the scary part, you might have missed the, what really is this? COVID-19 is an illness that's caused by a newly identified coronavirus. And a coronavirus is one of a family of viruses that have a similar structure, and they cause disease in both people and animals. And some coronaviruses cause mild upper respiratory symptoms. Some of the common cold symptoms can be caused by coronaviruses. Others you may have heard of, like severe acute respiratory syndrome, SARS, or Middle Eastern Respiratory Syndrome, MERS, which circulated, years ago, and have caused outbreaks of much more severe respiratory disease. COVID-19 is caused by a new virus that was first identified in China, but now, as you can see, this is a map from the Johns Hopkins website, is really spread worldwide. The virus itself has been named SARS-CoV-2, so it's a severe acute respiratory syndrome coronavirus 2. And COVID-19 is the disease that it's caused. It's COVID stands for coronavirus disease, 19 being that it emerged in 2019. So we've heard a lot about social distancing, and I thought I would introduce Rob Hallowell and let him speak a little bit about what that might be.
Yeah, thanks. So social distancing has definitely been a buzzword in the media, and I know we've all been told to practice social distancing, and this is not something I'd ever heard of before a few weeks ago. And so I think it's important that we dive a little bit deeper into the term just to have a full understanding of what is meant by this. And when we talk about social distancing, I think we can think about it both literally in the concrete sense of the word, and then more in the abstract sense. And I think both are important. Literally, social distancing is keeping a distance between you and other people. So imagining sort of a 6-foot bubble or barrier around you, keeping a distance of 6 feet between you and any other human being in the room. And this number was come up with because in general, if people are breathing heavily or coughing, that is what we think is the most reasonable distance to keep you safe from droplets or respiratory secretions that could be infected with virus if other people around you have COVID-19. And so if you imagine yourself out in public, if you keep this distance between you and other people who are out in public, you have a much reduced chance of catching the virus from those people. So that part is, I think, the easiest part to imagine. You know, if you're out and about and you see people around you, you can envision sort of this buffer between you and them, and you sort of keep distance. And when you go to stores now, a lot of places are even putting, blue tape on the floor telling you not to cross that line until the person has crossed the other blue line in front of them, etc. I think in the more abstract sense, though, social distancing gets a little bit harder. And this is where society is really sort of called upon to self-isolate. And this is what's really been, I think, the hardest part of this, because this is where we've all been asked to keep to ourselves, to stay at home, to avoid going into public spaces, and prevent ourselves from finding ourselves in situations where we could come in contact with germs and people who may be infected. I think the easiest way here is to use some concrete examples. Going to a grocery store or going to a pharmacy to pick up necessary supplies is okay, assuming that we're careful to keep our hands clean and maybe wipe down the cart and stay 6 feet away from people when we're there. So social distancing allows us to do those things. But having family over for a birthday party or having a gathering in our house is not acceptable under social distancing, because even if we're not hugging or kissing those people in our houses, we're still bringing people into our home who could bring germs, and those germs can cover our countertops, etc. It's okay to go out in public and walk in a park and get some fresh air, but it's not okay if those parks are crowded and we're physically close to those people. And so I think this is where there's been some confusion, and I know even my own family calls me constantly asking, can I do these activities? Can I not do these activities? And I think it really comes down to doing everything possible to limit your exposure to other people outside your immediate home and your immediate family, because every contact with another person increases your chances of exposing yourself to the virus. And I think this is just a moment for us in the healthcare community as a whole to pause and thank all of you, because here on the front line, we're doing our part to treat and to heal. But everything you do is vitally important, because your job is equally as difficult. Social isolating and quarantining and staying in the home and not seeing your families when you're afraid and anxious is extremely challenging, but it's vitally important. And you doing this makes our job easier, and it makes it possible for the nation to heal. And I just want to thank you for that, because I know it's not easy.
Can I just, it's Sonye. I want to just drop in a question that has been asked, which is relevant to what Dr. Hallowell just mentioned. Specifically, a number of people have asked about the whether it's safe to go and pick up medications at the pharmacy, since many people do need to have those prescriptions and their pharmacies may not deliver. Dr. Hallowell, could you just comment a little bit on that, and on, I think you'd mentioned a bit about grocery stores, but a little bit about what people should be thinking about if they need to go to the pharmacy to pick up their medication?
Yeah, I think that's a really good question, and this is one that comes up repeatedly in our clinics when patients call. I think, ideally we try to limit our contact with the outside world and crowds in general, but there are some necessities that can't be avoided, and things like getting groceries or getting prescriptions from the pharmacy are necessities. If we're in a position where we have somebody who can go to the pharmacy for us to pick up those prescriptions, that is preferable. But if that's not possible, then certainly it is okay to go to the pharmacy, take precautions, washing our hands when we get back from the pharmacy to make sure that we've removed any germs as much as possible. But for the most part, when people are going to pharmacies now, they tend not to be crowded. We can keep our distance when we go, and the pharmacy staff are now very sensitive to this, and they're taking precautions themselves to try to keep patients safe. But we'll kind of get into this a little bit later, but it's also very important that patients continue to take the medications they're prescribed to keep themselves healthy in all other ways. So those pharmacy trips do become vitally important.
I would add into that, this is Amy, I have seen that there are several national chain pharmacies that are offering delivery for medications for, refills and things like that. So you might look into that in your area. And then there are several, certainly in my community, that have drive-through windows so that you don't necessarily have to go inside, but can minimize that exposure at a pickup window or something like that. So certainly thinking about those logistical options is appropriate as well.
Yeah, that's a really good point.
That's a great question, though. So moving on a little bit about how does all of this help and make a difference? Why am I staying in my house? These are a little out of order. So we know that COVID-19 is actually very contagious, more so than influenza, for example, to which it's been compared a lot, and is more severe than the common cold, for example, which can also be kind of contagious. But it can be spread by people that don't have symptoms. So you don't necessarily have the awareness that somebody can spread COVID-19 when you're interacting with them. So imagine the spread from one person. If every person infects between 2 and 3 other people, I'm sorry, this moves really fast, but it can actually propagate to, an exponential number of infected folks without these mitigation strategies that we're talking about. So working from home, avoiding, gatherings with friends and family, unfortunately, not traveling, things like that. If we limit our interactions with other people and have fewer contacts from the people that are infected that either know it or don't know it, then we can certainly lessen the spread of the virus itself. Now, COVID-19 is not just another flu. It's more contagious, so easier to spread. Every one person with the flu seems to infect about 1.3 other people. So not a huge spread. In contrast to that, every person with COVID-19 seems to infect between 2 and 2.5. I've seen as high as 3 people. So we can see that exponential spread, particularly with the asymptomatic people who don't know that they have it that are passing it along. The time it takes for a person who has been infected to show symptoms is a lot longer. They can be asymptomatic and spreading disease without knowing it for up to 2 weeks. And so they can really contact, if they're not social distancing and isolating, they can contact a lot of people. Think about all the people you might come in contact with in 2 weeks, between chores and household tasks and, supplies, going to the grocery store, people being at work, at school, at kids' activities, things like that. Then the hospitalization rate is a lot higher with COVID-19 than it is with seasonal influenza. About 2% of flu cases end up in a hospital. We're seeing something like 20% of known COVID-19 infections ending up needing hospitalization. And in terms of mortality, the mortality of COVID-19 is actually seems to be quite a lot higher, on the order of, at least 10%, probably more than that, than seasonal flu. So it is more contagious, more spreadable with an asymptomatic infection, and more serious. So it's expected that a lot of people will get COVID-19. You might have heard in the news reports, in the millions across the world, and we're worldwide probably going to hit 1 million cases pretty soon. If that peak is really fast, then the percentage, remember about 20% of that number needing hospital care, has the potential to overwhelm the systems that we have in place. And so that is what we mean when we use the term flattening the curve, okay? So if a lot of people get it very quickly, that curve is very steep. And the 20% that need to have hospital care, the percentage that need to have ICU level care, can go over the threshold of what our healthcare systems can handle. And that's what we're hearing stories about in places like New York and Italy. that these places are getting overwhelmed by those numbers. If the curve is flattened, if it bends, and fewer people people get infected, but maybe not as quickly, and that allows for some people to recover before others get sick, and maybe a smaller number get infected overall, we don't overwhelm those hospitals and resources. So the fact that there isn't a vaccine yet available, developed, we're working on that, but there isn't one. And so really the only prevention that people have is to avoid that exposure, okay? And flattening the curve, like you're seeing on your screen, gives science and medicine time to develop effective vaccines for prevention, and then to also study potential treatment. I've had people ask me, this may be a question that's come up, how long is this going to be going on? I think that we would anticipate that this will go on in the United States for some time, probably several months before these sort of restrictions to movements and interactions can be lifted. I certainly won't speak to the legal implications of all that, the governmental implications, but the risk, once we pull back from those things, there is a risk that cases will increase again and spread will increase again once those restrictions start to lift. So we want to be very sure we're past the peak of this when we're looking towards loosening those restrictions on people's movements.
I might just pop in here with a couple of questions that have come in from the webinar. I wanted to just ask Dr. Hallowell if he would discuss a point that came up from somebody about social distancing. And I think that the question is really, when we think about social distancing, who are the people that it is okay for us to remain in close contact with? And then on the other side, who are the people that we should apply the social distancing to? Would you be able to answer that question, please?
Yeah, I mean, I think this is a tough question, and it's a tough answer to give. But I think essentially, the more people you come in contact with, the greater the risk of getting infected. And that's just sort of the inconvenient truth here. And so this means that people have to make some really tough decisions. And, obviously it's very hard to social distance from your spouse or children that you live with. And so, you're going to be in close contact with those people. But most of our families, we are recommending that they don't have their grandchildren come over to visit. And if they're older and they're in high risk groups, that they don't have their children come over to visit, especially because their children or their grandchildren tend not to be exercising as strict social distancing guidelines, and certainly could be asymptomatic carriers. And this sort of gets to the point of how, as a society, we all have to play our role. I will say that one of the issues that I take with some of the ads and the commercials I see, and sort of getting into the point, and this sort of segues into some of our other slides, is sort of talking about patients who are high risk and practicing the social distancing when you are high risk. And I would argue that everybody needs to be practicing the same level of strict social isolation and distancing regardless of their risk, because everybody can still be asymptomatic carriers. And so I think if you're a high-risk patient, and I think I would argue if you are listening to this right now, you are a high-risk patient, you really should be limiting your contact to anybody outside of your immediate family, meaning anybody that you don't live with, really should not be coming into your home and visiting you on a regular basis if not necessary. And that's extremely difficult. That means that birthdays and special events and visits are all limited to FaceTime or telephone calls. And, you know, visits and family are extremely important, but so is staying healthy. And I think that's part of what makes this so challenging. But I think if our ultimate goal is to keep people healthy and out of the hospital and, to be perfectly frank, alive, I think those are the extreme measures that we're asking people to take.
Thanks. I think that's a very, very good point, that really what we're talking about is people who are primary household contacts, so perhaps your spouse or live-in partner or children, but trying to limit the contact with people who live outside of your home on a regular basis. And I think I heard Dr. Case also wanting to make a point on that. Please go ahead.
Sure, thank you. Yeah, I would also add to that there are people for whom outside help is really necessary. Caregivers and things like that may not live in the home, but really are essential to some of our community's well-being. And so I would ask everybody just to think critically about what is essential and what is convenient when it comes to having exposures outside of your immediate household. Just like we were talking about going to the pharmacy or to the grocery store, those would be essential. Perhaps going to the hair salon is not so essential. I'm finding out myself as an anecdote. But there are people for whom having that outside exposure, although we do, in general discourage that, it is still part of essentially being able to function. And so it may be important, but let's just be thoughtful about the level of need.
Now, one of the questions that has come up, and I think that it's something that we have had this discussion with many of our patients as well, is if our patients who have pulmonary fibrosis need to go out of the house, should they be wearing a mask when they go out? And Amy, would you like to start with this, please?
Sure, I'd be happy to. So at the moment, and I probably should have prefaced this whole talk with that, the recommendations and what we know and don't know is changing almost multiple times a day. And how systems are handling this is changing pretty rapidly based on what we have available to us in terms of resources and what we know about the virus. And so as it stands, there is not currently a CDC recommendation or guideline that is supportive of using a mask in everyday life. There are probably a few reasons for this. We certainly would like to make sure the healthcare providers that are taking care of patients in healthcare settings have access to this type of personal equipment, personal protective equipment. And if you've seen any of the news, there are some challenges with supplies in those areas. There's a lot of discussion about use of face coverings or masks in the general community. I think the thought so far has been that it may add some protection from if you are a person who is infected and might be spreading it to others through a cough or something like.
Amy, I think we just lost your audio. Rob, did you want to jump in at this? Yeah, thank you. Now we've got you back. Thanks.
Is that better? I'm sorry. I promise I am stationary. I guess what I was saying is that if people do choose to have a face covering, we don't want people to think of that as being a very effective prevention or protection against contracting the virus, really the best strategy is isolation and avoidance of exposure. But perhaps it would be a good mechanism for not touching a surface and then touching one's face, which is something that we certainly caution against doing. I don't know how much of that you missed, Sonye, but
nope, that was perfect. Thank you. Thank you very much.
Okay, so moving on a little bit, we wanted to talk about what COVID-19 might mean for patients with pulmonary fibrosis, and that was actually a nice segue. Rob, would you like to talk a bit about that?
Yeah, so I think I sort of alluded to this a little bit, and I think just by the nature of the underlying disease, any patient with pulmonary fibrosis, I think, would be considered a high-risk patient, not only because oftentimes patients tend to be in an older demographic, but even without that, having an underlying lung condition would place patients with pulmonary fibrosis or any type of interstitial lung disease, at a higher risk of having complications from COVID-19 or any viral infection. And so that's not to say that the risk of catching the virus is higher, but should you catch the virus, the risk of having a complication or becoming sicker from the virus, I think is higher. And so that's all the more reason just to be, extra cautious and to sort of follow all the guidelines that have been put forth by the government and the recommendations that we're talking about today. And all that's to say that, caregivers themselves of these patients really need to take good care of themselves in order to keep themselves healthy and to try to prevent themselves from becoming sick or asymptomatic carriers. And so, it's not helpful if a patient with pulmonary fibrosis does everything they're supposed to and practices social isolation, but their partner then is going out constantly into crowds and exposing themselves, because then they're bringing that risk of infection home with them every day. So it really has to be sort of a team effort. And, we talk about, good hand hygiene and hand washing and, avoiding handshakes and that. And I think one thing that people, very easily forget, and I am guilty of this constantly, is that things like cell phones are filthy, right? We put them down, we pick them up, we eat with our phone in our hands, we very infrequently sanitize our phones or wash our phones down. But just because you wash your hands or clean your hands, the second you touch some other surface, your hands are dirty again. And so, as a society, especially in America, we're very used to eating on the run and eating while doing something else, which very quickly makes our hands contaminated, potentially with virus. And I would encourage everybody to get in the habit of stopping and eating just for the sake of eating. And that will actually keep your hands cleaner while you're eating. It's also just a good practice, quite frankly. You'll enjoy your food more and probably eat healthier. The other thing I would also recommend is to wash your hands really well before you go to bed, because your hands, if they're dirty before you go to bed, once you're sleeping, most of us touch our faces constantly, either in the process of falling asleep or while we're sleeping, and potentially wash your face as well, because parts of your head and face get dirty before you put it on your pillow. So just little tips to think about, trying to keep yourself as clean as possible throughout this. I'll stop there.
All right. So one of the big things that I think we all have to remember is that, COVID-19 is a reality for us now, but it doesn't mean that all the regular stuff shouldn't be still prioritized. And I think for a lot of our patients, that often means remembering to take your medicines and use your oxygen if it's been prescribed as necessary. We've talked a little bit about oxygen in terms, about medicines in terms of going to the pharmacy to pick them up. Somebody sent in a note to the webinar just to say that some pharmacies are actually offering to send medicine by mail, so you might want to look into that. And I think that the other thing to think about is knowing that healthcare professionals are quite busy right now. Try to plan in advance if you're going to need medication. And in fact, try to have several months worth of medication on hand so that you don't find yourself running out and not having an opportunity. You heard also a very important piece of information from Bill Schmidt at the start of this, which is that Medicare has waived their typical rules for face-to-face encounters for qualifying or requalifying for oxygen. So if these are some of the issues that you're facing, please reach out to your providers just to let them know that those have changed, and if you need oxygen, to make sure that those prescriptions are refilled. One of the other questions that's come up quite reasonably is that many medications that patients require have safety labs that need to be drawn at certain periods of time. And this really is an issue that has to be determined on a case-by-case basis with your physician to determine if you've been on a medicine for many, many months and your numbers have been stable. Perhaps they'll say, well, wait an extra month or wait a couple months before you get your routine labs done. On the other hand, if you're new on a medication or if you're on a medication that has a significant risk of a side effect, they may feel that it's important for you to go in and have your safety labs drawn. So that really is going to have to be determined on a case-by-case basis. But know that because of this COVID-19 pandemic, it doesn't mean that issues like that can be ignored. In terms of getting routine care, many people are scheduled to see their physicians on a regular basis, and your physician may have reached out to you, or their office may have reached out to you to say, hey, rather than having you come into the office, we'd like to take care of this by webinar or by telephone. And that's a practice that's being used at many centers. And again, the strategy is to try to avoid bringing together people who are not in the same household, who might take a healthy person or a person who's not infected and bring them in contact with somebody who is infected. So please reach out to your doctor's offices if you have routine visits scheduled. See if these are routine occasions where you might push it back a few months until things are a little bit less active in terms of the COVID-19 infections, or whether you might be able to convert it to a telehealth visit. Now, certainly that doesn't mean that if you have a concern, you should delay talking with your doctor about it. Your doctor is even more important now as you try to think through your symptoms and know what the appropriate decisions are to make if you have a change in your symptoms. Could this be something related to your interstitial lung disease, or could it be something related to an infection? So please don't hesitate to reach out to your doctor's office to try to get guidance on this, because again, this is going to be something which needs to be discussed on a case-by-case basis.
Thanks, Sonye. So I would also add that, and no, we've had some questions at our site about research visits. There a lot of research visits and research sites have altered their approaches and schedules now. We can't answer really specifically for every individual, but I would encourage everybody to check with their study site ahead of time, because they might be making some modifications. But there may be, just like Sonye mentioned with important labs and safety checks, there might be some important safety elements that need to be addressed in person at your research site. So check with your coordinator in your site about that, and specifically. Additionally, just to address pulmonary rehabilitation, that is likely to be closed in a lot of places. It's certainly closed in our institutions. But there are some online resources for keeping moving in the interim. And I know there's some online resources if you've already been in a pulmonary rehabilitation program that might help you keep active in your own home while we're practicing social distancing. And with regard to support groups, I know a lot of our pulmonary fibrosis patients really rely on those. I think most of our PFF support groups are postponing or canceling or moving to virtual meetings to continue to practice social distancing. And the PFF virtual groups are still meeting. So the telephone-based support groups that meet regularly. So if you'll watch communications from the PFF, then you can certainly hook into those if your local group has gone on a hiatus for now. So we can still offer that type of support to each other.
Amy, one of the questions that came up is we've talked about social distancing. We've talked about the importance of exercise for our patients. Is it okay for our patients to go outside to exercise? And what would be the guidance you would give in that situation?
Sure. I highly recommend getting outside. It's a great way to relieve some of the stress of being cooped up indoors. If you're able to do that, either in your own yard, if you've got one, or in a neighborhood, or potentially if your parks are still open on a walking trail or something like that, just be mindful about how close you're getting to other people if it's a very busy time of day. And I would recommend avoiding places, indoor places that if you're at the park, any indoor facilities like restrooms or playground equipment, swings and things like that. But if you're walking on a trail and you're appropriately distanced from the other people that are enjoying the outdoors, I think it can be a really refreshing experience for everybody who's getting a little cabin fever.
I think that's a really important point. We're not saying when we talk about self-isolating and social distancing, we're not really trying to imply that you have to lock yourself into your house. You have to use good common sense in terms of being in other places, but certainly the outdoors offers a tremendous opportunity for you to get some exercise and fresh air. And I think it's very important because it can be quite stressful to spend all of your time within the four walls of your house. So getting outside is a really important opportunity and option for people to get a bit of exercise and some good mental health breaks.
I would emphasize walking with people in your own household and not meeting up with people from other households, just like we were talking about before. Rob, do you want to move forward and address, what happens if our patients do get sick, either with COVID-19 or with something else?
Sure. So I think we'll start first with possible symptoms of COVID-19, and I think the first thing I'll say is that a lot of the symptoms are somewhat nonspecific in that this is a respiratory virus, and there's nothing particular about this virus and how it initially starts out. So the cough or fever or headache or chills, are really kind of some of the mundane symptoms that would start with any kind of common cold. A lot of patients are initially reporting just a mild sore throat. One thing not listed here that we've seen also in our community is people lose their sense of taste or their sense of smell. So there can just be some subtle findings. I think in that setting, I think it's just being mindful that, with sort of the high prevalence of the viral in the community, I think the assumption has to be that if you have any symptoms at all that could be related to a viral process, including GI symptoms, because this virus can affect the GI tract, so diarrhea, nausea as well, we need to just make the assumption that you could be infected with COVID-19 and therefore contagious, and to try to limit your exposure even further to people, although at this point we should all be social isolating. I think what becomes, a little more concerning and sort of at what point do we sort of escalate this up in terms of needing to seek medical care, would be sort of a threshold of really high fevers, changes in the way our breathing feels. So our baseline level of windedness or shortness of breath, if there's any change in that at all. So, that flight of stairs, that slight incline that we know so well outside our home, the simple tasks that we're doing inside our house on a routine basis, whether it's laundry, etc. If there's any change in the way our breathing feels doing those things, patients who are on oxygen or not on oxygen, but have a finger pulse oximeter and measure their oxygen levels, if there's any change at all in those oxygen needs or oxygen levels, I think that would be a sign for concern. But I think getting to a point that Sonye made, I think if any of these symptoms develop, I think looping in your healthcare provider early on and giving them a heads up and saying, hey, I'm starting to have these symptoms, so that your doctor can sort of follow along with you step by step and monitor you closely. I think that's crucially important. Mild symptoms, whether it's COVID or not, does not require hospitalization. It's difficult to get testing in the outpatient setting depending on where you live. And so you may not even be able to confirm that this is COVID-19 depending on your region. And we may not necessarily bring you into a clinic, but certainly we're going to want to keep a very close eye on you, given a history of lung disease here. And so certainly if there's something else going on and it's non-COVID related, I think this is where, it gets a little challenging. I think we certainly are making every effort we can to deal with non-COVID issues outside of the clinic and outside of the hospital setting as much as possible, because we don't want to expose patients to the possible risk of getting an infection, in the clinic or in the hospital. But this is going to be sort of, on an individual basis. And, you and your doctor are going to have to decide if it's something that has to be dealt with in person, face to face, and sort of the risks and benefits of coming in to deal with that, sort of the same way we were discussing, how critical blood work is or is not. But those decisions are going to be made sort of going forward, and that's why it's important to loop your doctor in early on as you sort of develop some of these symptoms. The majority of patients who get COVID-19 do okay, but we need to monitor these things closely from the beginning. So call your doctor early. I'll stop there.
Thanks, Rob. So I wanted to transition a little bit into how do we cope with all of this? Social distancing, we've talked a little bit about the logistical challenges and the things that we normally do every day that we don't even think about, like going to the grocery store, becomes some challenge now. So we would recommend making sure that we have medications on hand. If we're getting towards the end of a prescription that needs a refill, I recommend calling your physician's office or requesting that refill a bit early if you're running low, so that they have time to send in a refill, and you can have time to go pick it up without running into a crisis of running out. As far as groceries and household supplies would go, there are certain things that we have to do, but if there are options, maybe we should choose those. For example, if you've got a family member, a friend, or a neighbor that really wants to be helpful, but you don't want them to come in the home to do anything for you, could they possibly go and pick up some groceries and leave them on the step for you or something like that? There are grocery delivery services that are out there, but you do have to plan ahead for those because there is a delay in having those orders dropped off. If you can pick up, order ahead, have those groceries and things shopped for you. For example, in our area, Kroger and Publix both allow you to put in orders. Walmart does the same thing ahead of time. You can drive up at a certain time, and somebody will bring those groceries out, load them in your car. You don't even have to get out. So that's another option. And then if you really do have to go out for something, try again to plan ahead, just to minimize the number of trips that you're making to a certain location and out of the house. There are places in some communities that have offered limited hours for seniors or people who have medical or physical challenges to come and shop in a less, a little less crowded environment where other people might not be there. And so those are some things to look into to try to help with those day-to-day activities. As far as maintaining a social connection, I have seen just an explosion of options for staying connected and staying entertained online. So we mentioned pulmonary rehabilitation locally might be closed, but one option that's out there, the Simmons Center at UPMC, is actually hosting some Facebook Live pulmonary rehab sessions. You can check on their Facebook page and maybe dial into some of those. If you check out the American Academy of Cardiovascular and Pulmonary Rehab, they have some resources on their website. I know that the YMCA has some online exercises like yoga and things like that that I get emails about every day. So there are some ways to bring that movement into your home and be able to try to at least stay active while we're limiting our movements. It can be really hard to be away from friends and family. So ways to connect could be scheduling phone calls, just making sure that we're doing wellness checks on everybody. I know some people enjoy good old-fashioned letter writing, which sounds silly in 2020, but can be enjoyable. And certainly there are lots of options for video chats. In my family, we use FaceTime and Google Chat, but Zoom is an option. Multiple family members in different locations can get together. And if you have kids or grandkids that are tech savvy, they could probably help you set up with those types of things. But they can really keep people feeling connected at a time like this when we're physically distancing, but hopefully not emotionally distancing. If you're missing travel, there are a number of virtual tours that are out there. My kids have done a few. The Smithsonian, the National Zoo, Mount Vernon. There are certain aquariums and art museums that have virtual tours that you can check out. And there are people that are taking up new hobbies and skills while they're hanging out more often at home. If you look at any social media, people seem to be cooking and baking much more often, exploring new books with book clubs, taking up different types of crafts and hobbies. And certainly the Pulmonary Fibrosis Foundation, as we mentioned before, has some ways to connect via the virtual support groups and also the virtual walk options too. So just some ways to maintain our social connections while we're physically distant from one another, because it certainly can be emotionally difficult during these times.
So, Amy, we've had a question that I think is a really important one to think about. And, we've been hearing a lot in the media about the fact that there have been sort of a certain number of days that we're supposed to be socially distancing. So the question is, well, what happens in 30 days? What's going to be the next step if that when we hit that 30-day mark? And I know that a lot of this is going to be really, for any of us, is going to be speculation because we have to wait and see what the numbers are in terms of the rates of infection and so forth. But the real question that was asked is, should those who are susceptible continue to stay socially isolated beyond the 30-day limit, the 30-day deadline that has been proposed at this moment in time? So, Amy, do you want to start with that? And maybe, Rob, you could also make some comments.
Sure. I think that is a really challenging question to answer, especially from here, and especially as quickly as things change. I think that the ability to test as it becomes more widespread will help with that. I think that there will need to be at some point the ability to be for people to be back at work and back in society. But it's hard to see what that looks like. And I anticipate, and this is just my own point of view, is that will probably be a slow return to normality or some version of that. That it won't be like the end of the apocalypse movie where everybody walks out of their house to sunshine and rainbows and it's all over. I think we're going to be dealing with this virus in some form or fashion, for many months to come. And whether we can get the outbreaks under better control will probably dictate how society is able to then respond to that. But I'm, in the practice of medicine, I've become very comfortable with admitting when I don't know something for sure. And I think we don't know what that far out really looks like. There's some predictive models, but we don't know yet. Rob, what do you think?
Yeah, I think that's a fair statement. I mean, I agree. The amount of uncertainty is incredible here in terms of knowing what the viral numbers will do. But I think you make a good point that, there's one thing to get over sort of the crest and over the initial, devastation when things are at their worst and the healthcare system is overloaded. And when we start getting into a period where people start breathing a collective social sigh of relief because it looks like we've turned a corner, that's very different than saying the coast is clear for our sickest, most vulnerable patients to go back into a normal sort of social role. And I imagine at some point we're going to start doing this in phases, where certain things start opening up, and the healthcare system will still remain extremely cautious. But for the most vulnerable patients, I think it's going to be a lot longer before we feel really comfortable saying the risk to you has passed, because we know there's going to be reservoirs of this virus out there for probably several months at least. And so, I think that the risk will dwindle, but it's going to take time. And knowing exactly how long that will be, I think we're going to need longer to see sort of what that trajectory is. And the fact that the past week seems like 2 months, I think is telling just how fast things have changed and the data has changed. So if, one thing coronavirus has done is take a profession that, certainly in the ILD realm, we've been humble to begin with because of the diseases that we treat. And now we're doubly humble as clinicians here. And we realize just how little we know about medicine and science in general. And I think we're going to learn even more about our own humility.
Well, I think that that's a really important point that all doctors should carry with them, is that as much as we know, there's so much more that we have to know. And I want to just ask you, Rob, to start with a question that really has come up in a lot of different forms on the webinar, which is the symptoms of interstitial lung disease and pulmonary fibrosis often overlap with the symptoms of COVID-19. And sometimes even being anxious about getting COVID-19 can cause someone to feel more short of breath. How would you go about thinking or advising a patient about when do they need to call, and what are the things that should be, a definite phone call, and who should they call? Should they call their primary care doctor, or should they call their pulmonary doctor? Do you have some general guidelines for that, please?
Yeah, that's a really good point. So, all of my patients as an ILD doctor, and I'm sure yours as well, Amy and Sonye, they all have symptoms at baseline, right? They all have dyspnea. Most of them are on oxygen. They all have a chronic cough, or many of them have a chronic cough. And so, it's very difficult to know early on if they could have mild symptoms of COVID. And I guess the first one point I would make about that is if if they have COVID and their COVID symptoms are so mild that it hasn't changed their baseline symptoms or their baseline functionality, then they're doing okay. And so if even with their underlying lung disease, nothing has changed, despite the fact that they have the virus, that means they're fighting it and they're robust enough, and there's nothing that I would do differently as a clinician at that point. So in that setting, if we're missing something, I guess it's okay we're missing something because they're compensated and they're doing fine. So I guess what we really need to know here is, what is the clinical change and the clinical threshold that would make me concerned that something could be changing in a way that would be concerning enough where they might not be doing well, and they could get into trouble that we would have to intervene. And so I would say those triggers for me would be any change in oxygen level. So patients who are on oxygen who start needing more flow. So if they're on 2 liters and they start needing 3 liters to keep their finger meter at the same level for any normal activity that they're used to, that would be very concerning to me. And certainly a change in their level of breathing, feeling more out of breath for a typical activity. You know, you talk about the anxiety component, and just, you know, being anxious about COVID can make us feel out of breath. And I think that's a really good point. We're all anxious now. You know, this is a time when we all have anxiety. And anybody who isn't a little bit anxious about it either isn't being honest with themselves. You know, and I think being anxious is a normal human response to this, and that's okay. To have these emotions, and we should recognize them for what they are, and we have different ways of coping with that. And I think I would say most people can, if they stop and pause, recognize that anxiety-induced shortness of breath it tends to be more fleeting and can be controlled with pauses or meditation or activities of focused or slowed breathing. And most of the patients we've seen who are getting sick or having COVID are noticing that their changes in breathing and their changes in shortness of breath or dyspnea tend to be more sustained. And, you know, there's nothing they can do to relieve that. And so it seems to be different and more real for them. Now, there's obviously some gray zones in between, but, you know, I think that's sort of the best we can do in trying to parse out that difference. And I would say, you know, in the end, if there's any doubt, you know, this is when you're calling your provider. And so to get to the next part of your question, you know, whom should you call? And I think a lot of that depends on the relationship you have with your doctor. Some of our providers, or some of our patients rather, have phenomenal rapport with their primary care providers. They've known their PCPs for decades, and they call them with all sorts of stuff because, you know, they're in town, and that's who they prefer to call first. I encourage all my patients to call me immediately with anything lung related. So I think it depends a little bit on the relationship they have with their local pulmonologist and their primary care doctor, and how they've sort of set up that relationship. But I know in my practice, my default is always, if it has anything to do with breathing or your lungs at all, you know, the call should come to me and my clinic. But I imagine there are probably some exceptions out there in the community with patients who have, you know, really remarkable primary care physicians who have very responsive offices.
And I guess that the other thing that you might need to think about is a lot of pulmonary doctors are frontline providers right now in the hospitals. And so if you call your pulmonary doctor's office and you're either given a message that they're going to be slow to respond or that they're not in the office and not available, then you might also want to reach out to your primary care provider, just because it gives you a backup system also to have another person involved with your care.
Yeah, that's a really good point, Sonye.
And Amy, I think you were going to finish up our slides with a couple of mythbusters, and then there's lots and lots of questions that I'd like to ask both you and Rob to try to address, since there are a lot of very interesting questions that have come in.
Great. Yeah, so I personally have answered in my own life a lot of questions about COVID-19. There's a lot of information coming at people really fast, and some of it is very fact-based, some of it is speculation, and some of it unfortunately is untrue. And so, so we have to be very careful and very thoughtful with our sources, and hopefully we can dispel some of the misconceptions here. One that I've heard is that there might be door-to-door testing or an at-home test that is currently available. Unfortunately, door-to-door testing is a hoax. That's not real. And there is not, at least as of yesterday when I last checked, there was not an at-home test that was available. That may have changed. But the premise of an at-home test, at least, would be something that wouldn't have an immediate result and would be sent off. So that's not something that that's currently out there at the moment. So please don't pre-order those or try to get one. Currently, to address the issue of testing, as Rob mentioned, it's really available differently in different parts of the country. And so we would recommend, if you feel like you need to be tested, to talk with your provider there about symptoms and so on, and behave as though that just assume positive until proven otherwise. We've heard a lot about the development of vaccines at a very rapid pace. That should be qualified, though, with the fact that a fast turnaround for vaccine development is probably looking at no less than 12 months and probably closer to 18 months. There are some clinical trials that are starting, vaccine candidates that have been identified, but right now they're really only in the safety phase. They're not even looking necessarily for efficacy, and that's a process that needs to take its time. We can't necessarily rush science beyond a certain point because we don't want to get it wrong. It matters a lot, and so that means for prevention probably won't be available until sometime next year, calendar year. As far as treatments go, this is a really loaded type of thing. It gets a lot of play in the media and stuff like that. We fielded a lot of questions about the drugs hydroxychloroquine and chloroquine. They are not proven effective treatments. They are being studied. And I'm not going to parse all of the data, Sonye and Rob, if you have comments here, that's okay. But we are not recommending those to have on hand just in case. Not really recommending those in the outpatient setting at this point. Now that data may change in a few weeks when we have more information from clinical trials available. Similarly, the combination of hydroxychloroquine and azithromycin, or azithromycin by itself, we wouldn't recommend just having on hand in case, because there really isn't a proven efficacy to those things being used. And we would just go back to, with regard to any of the treatments that have been talked about and are being looked at and studied, that the old adage, an ounce of prevention is worth a pound of cure. Really, the most effective thing that we can recommend at this point is avoiding it being exposed. And we've said it at least a dozen times, but it's so important because, even the things that are being studied and might show promise are not going to be uniformly effective, I wouldn't think. Although science is moving at a breakneck speed right now, which is really encouraging to see that so many institutions and researchers are working together so closely. With regard to, contracting the virus, you shouldn't be able to get COVID-19 from picking up groceries off your front step or taking deliveries or Amazon boxes or mail. But we would recommend continuing to wash your hands very frequently. So if you've been out to the mailbox or picked up a delivery, wash those hands, right? Just keep going back to the things that the basics. They do work. They are helpful. We've heard that at least in the initial reports that younger people weren't being affected by this. at least not in the rates that older people were, but that older people are certainly at higher risk for severe disease, but young people are getting sick all over the country with COVID-19, but they can also be carriers and pass it to others. So they need to be just as cautious as the rest of us because we're really all in this together. Two last things I would address in this is medications that people are currently taking. There's been a lot of talk about ibuprofen in the news media, and there may be some mixed opinions about this from that standpoint, but there's actually no research that shows that ibuprofen should be avoided for coronavirus or COVID-19. However, for those patients who are, in the hospital, who are at risk for renal injury and things like that, the doctors there may choose not to use that agent. But if somebody is using it at a stable dose for whatever reason in the outpatient setting, I wouldn't recommend discontinuing or altering that just because COVID-19 is out there. And finally, people might be on ACE inhibitors or ARBs, medications for blood pressure. There has been a lot of talk about that, and I would caution everybody not to stop their blood pressure medications because COVID-19 is out there, and also not to try to get started on one of those things because COVID-19 is out there. We really shouldn't be altering those maintenance medications to try to prevent or protect from or treat COVID-19. So that's a list of some of the things that we've been fielding questions about. I know there are lots more, and we wanted to leave some time for people's questions. And Sonye, I think you're seeing those. We can go through as many as we can.
Yes, absolutely. And there are many, many good questions. So I'd like to try to cover a few of them at least. One of the questions that came up is about people who have been infected with COVID-19, whether there's any evidence that they develop immunity after that. And maybe, Rob, do you want to talk about that just in the general context of other viral infections and developing immunity?
So in general, if this virus behaves the way other respiratory viruses do, and from what we can tell, it has not been mutating much at all over the past few months, people who have a significant infection from this and significant symptoms, in theory, should develop immunity. However, that being said, there have been some cases around the world of people becoming infected a second time. So there are some case reports of that, although extremely rare. And like with all infections or all vaccines, and so getting infected with this is sort of akin to having a vaccine to it, since that's how some of our vaccines work. Effective immunity is based upon your immune system's ability to form the appropriate antibodies to the virus. And so patients who have a decreased immune system because of certain medications that they may be on, so immunosuppressing medications, and patients with certain underlying medical conditions may not mount an appropriate immune response to the virus. And so they may not have the appropriate levels of immunoglobulins against the virus, and so they may still be susceptible to getting sick again. This is an active area of research right now. We are devising assays to see if people are developing effective immunity after being infected. But we just don't have a good answer as to, what percentage of people after being exposed or infected have true sort of ongoing immunity to it. But in theory, as more of the country gets exposed and gets infected, people should be getting some level of immunity to it. It's just hard to say that you're going to be, 100% safe just because you've had it once.
So it sounds like if we can draw some things from what we know about vaccinating for things like influenza or people having influenza, that there is probably going to be some level of immunity. It might not be lifelong immunity, but it's certainly more likely that people will be immune after having had it or being vaccinated for it than they would be now, where it's a new virus that none of us have seen before, and so our immune system doesn't have any way to respond to it based on our historical interaction with it. There have been many questions that I think are actually very important, and I'm going to ask both, maybe Amy will start and then Rob, you'll follow on with this, is I've had dozens of questions about what would happen if somebody who had interstitial lung disease or pulmonary fibrosis were to get COVID-19 and need to be on a ventilator. There's lots of concern about whether decisions need to be made about whether, they should be intubated or whether there should be, it's a strain on the healthcare system or what should be done. And these are really, really tough questions because it really requires not only thinking about the individual, but thinking about society as a whole. And I'm going to ask my colleagues to start, and then I think I'll take the prerogative of having the last word on it. Amy, would you mind starting?
Of course. So, as you said, that is a really tough set of questions. I think my input on the answer here is to go back to what we're hopefully encouraging everybody to do at every stage of their disease, and that is to think and plan ahead for whatever the future might bring. Have discussions with your family, caregiver, next of kin ahead of time so that decisions, should they need to be made, are not having to be made in the setting of a crisis, that they're done ahead of time. And so there are some different tools out there to help with that. Certainly if you're having a video visit, a telehealth visit with your doctor, they can help you with some of those, conversations and concerns. But it's important, be it coronavirus or flu season or just, Wednesday, that we think ahead and plan ahead and have a backup plan for if we don't stay perfectly healthy, what we would have done in our best interest and for ourselves, and have those decisions communicated with the people that know us best. Rob, I took the easy part.
Yeah, thank you. Well, I certainly agree with everything you've said, Amy, and I think that is the key, is to have those discussions early on. But I think the harder part of that question becomes an individual one. I mean, I think obviously the situation of each patient is different depending on the severity of your underlying fibrosis, your age, how much oxygen you're on to begin with, and how sick you may get. We're at this point in America, we haven't reached the stage where we've run out of ventilators yet. We haven't reached a stage where the ethical committees of the hospital have had to make those tough calls in terms of rationing these resources. And I know that's what this question gets at. And these are things that as healthcare providers, we pray we never have to deal with, because it goes against everything we hold sacred, to ever have to make this kind of decision or think about. And it's never anything we want our patients to have to think about, to have to make a decision based on society, not their own personal preferences. And I think the fact that people are even raising this question in light of the greater good of society shows how such a horrible situation brings out the best in people as well. I mean, what a selfless question to ask. And once again, I'm just moved and inspired by all the listeners out there that this would come up. I think that I would shy away from ever making a blanket statement that just because you have an underlying lung condition, you should never want to consider fighting for your own life, because I think there are instances where people's underlying lung disease is not so severe that you don't have a chance of coming through this, and we've seen cases come through this. And I think if your lungs are healthy enough and we have the resources to get you through, we will fight to get you through. I think if things were to get bad enough and we were to find ourselves in a rationing situation, hospitals have ethical committees that are trying to answer these questions, and we have protocols in place, and some of those decisions may actually be taken out of your hands, to be honest, and it may not be a decision that you're making. You know, I think it's something that you discuss with your family. I think it's something that you think about for yourself and what you would want for yourself. And there's no right or wrong answer. And I think that's really the best I can say on the topic, to be honest.
Well, I appreciate what both Amy and Rob have said. And I think that, you know, again, this is something that brings us back to the fact that we all have to deal with, you know, with the realities of our medical conditions. And one of the perhaps silver linings of this illness, of this COVID-19 pandemic, is it's making everybody stop and think about what their priorities are and how they want to live their lives. And I think that this is really, there isn't an answer as to what to do, but there is the opportunity to use this moment to spend time with your family, either in person or by phone, and tell them about the things that matter to you and about what you would want to do if you were in that situation. And that will give them the capacity to do the right thing if that ever becomes necessary. And certainly we hope that the advice and guidance that we've given you today will help to prevent you from finding yourself in that situation, and that this will be only a theoretical conversation that will help your family members know better what's important to you. But surely this is a discussion we should have, all of us, each of us with our families, because ultimately we're all going to reach a point where a decision may or may not need to be made about how to guide our physicians if we do become critically ill. And I hope you will take this as an opportunity to express your views to your family so they can do the best that is possible for you. There have been many, many other questions, and I really thank everybody for all of the questions that they've posed to us. I hope we've answered the majority of them. There are some that I think we still don't know the answer to, but hopefully we will have more that we can offer in the future. And I just wanted to give both Rob and Amy an opportunity to maybe just say a word or two to finish up, and then I'd like to turn it over to Bill, who has a few more announcements before we finish this call. So thank you all for participating. And Rob, can I just ask you if you have a word or two to finish up with?
Thanks, Sonye. Well, it's been a real privilege getting to share my thoughts with you all today. Certainly unprecedented times, but as I've said, this has shown me the best in people, and we will get through it. Thank you for doing your part and for all of your hard work to keep each other safe, to keep yourselves safe, and for making our job easier. We really do appreciate it. Take care of yourselves.
I want to thank Rob and Sonye for participating, and thank everybody for logging in and listening and for some great questions. I'll just echo what Rob said. I have been humbled and in awe of my colleagues and my community and everybody out there who is behaving as we are, as though we are in this all together, and supporting one another through a time that's not easy for everyone. And I'll just finish by telling everybody the two things that I say when I sign off on things: stay safe and wash your hands.
Well, thank you, Amy. This is Bill Schmidt again, and I want to again thank everyone for attending this webinar, and I also want to thank our wonderful featured speakers today, Drs. Danoff and Hallowell. We really appreciate your participation here today. It was very, very informative. We realize that there are still a lot of unknowns in what is a rapidly evolving situation here. So we are planning to host another COVID-19 update in about 2 weeks, when we will likely have more information to share with you. In the meantime, I would encourage you to utilize the PFF website, pulmonaryfibrosis.org, for updated information on the COVID-19 situation and issues, as well as many other topics, including our recently added position statements on genetic testing and counseling in suspected familial pulmonary fibrosis. And very importantly, if you have questions that were not addressed today, always feel free to contact our Patient Communications Center. And again, that number is 844-825-5733. Again, 844-825-5733. And again, thank you, everybody, and stay safe.